Physicians Malaysia. The theme of the month is palliative medicine, and we are very fortunate to have Dr. Yap Choi Ling as our speaker for today. A few words about Dr. Yap. She is currently the head of palliative medicine services in Perak, and she's currently the head of the palliative care unit in HRPB Ipoh. She's also the visiting palliative physician for Taiping, Manjung, and Batu Gajah. She has contributed to research, CPGs, and training of nurses, MO, and specialists in the field of palliative medicine. Without further ado, let us welcome Dr. Yap.
Yeah. Thank you, Dr. Kelvin. Good afternoon, all my beloved colleagues. So I would like to thank College of Physicians for inviting me to chair this webinar. And today we are very fortunate to have Dr. Ling Chu Xian with us. She is currently a palliative care specialist in Hospital Kuala Lumpur. She graduated from Malacca Manipal Medical College in the year 2008, and she completed Master in Internal Medicine in 2016. Subsequently, she joined subspecialty training in palliative medicine under Ministry of Health Malaysia, and she completed her training in palliative medicine in year 2021. Currently, beside doing palliative care work, she also in charge of medical work. So she's also a palliative internal medicine specialist in HKL, and also a visiting palliative care physician for IJN referrals. So she has a lot of experience managing patients with cardiology issues. So without further ado, I would like to pass the time to Dr. Ling.
Thank you, Dr. Yap, for the kind introduction. Sorry, just 1 second. Let me just adjust my slides. Sorry, can you all see the slides?
Yes, can.
Yes.
First of all, I would like to thank the organizer for the opportunity. I'm very grateful to be able to present this topic in this webinar. So my name is Chu Xian. I'm a palliative physician in Hospital Kuala Lumpur, and the topic given to me today is the role of palliative care in patients with cardiology issues. So this is the agenda that I'm going to speak on today. I have divided it into 4 parts. I will start off with an introduction, and I will deal with 2 main questions. The first question, why refer to palliative care? Question number 2, when to refer to palliative care? And I will end with a simple summary. Doctors in general, we became doctors because we want to save lives. We sometimes feel that we are like Superman. We want to save the world. And we many times view that death and dying is a failure. Due to our workload, many times we have lack of time. We would like to spend more time with the patients, but we really don't have enough. Another thing is that for patients with cardiovascular disease, the trajectory is very unpredictable. Worst of all, when do we stop? So this is how many people view palliative care. They think we are death angels. So I've been into a ward to see a case that was referred to palliative care, and the nurses saw me and told her colleague, palliative sudah sampai, dia akan start morphine, patient akan mati sekejap lagi. So that is the misconception that people feel about palliative care. What do most doctors think when they hear palliative care? They think that we are very doom and gloom. We are very dark, very down, very serious. However, in actual, palliative care is a very happy place to be. About 6 million of Americans have heart failure. And out of that number, about 5% will progress to advanced disease per year, which is stage D. And a large percentage of the healthcare dollars is spent on managing patients with heart failure, a lot of it in hospitalizations and also end-stage care. AHA defines palliative care as patient and family-centered care that optimizes health-related quality of life by anticipating, preventing, and treating suffering. We focus on communication, shared decision-making about treatment options, advanced care planning, attention to physical, emotional, spiritual, and psychological distress, and we include the patient's family and their care system. Palliative care is never a standalone care. This is the structure of palliative care, where you can see that it is multidisciplinary and multidimensional. For the patient with heart disease, they will be surrounded by the cardiology people, the people from primary care, and also palliative care. And they also require multidimensional, which is the community, their neighborhood, the religious affiliations, and also the psychosocial people, which are the social workers, the psychologists, and also other healthcare people, such as physiotherapists and occupational therapists. Why refer cardio cases to palliative care? So I've heard of cardio fellows asking this question. And in fact, they feel it is killing the patient when they refer to palliative care. Such an interesting thought. So I also was pondering, I know what I can do, but am I really doing something to help? This is a question that I constantly reflect on whenever I see patients after a period of time, because I have to understand whether I'm doing what I want to do and whether I'm able to help to make someone's life better. So I had a call, I made a phone call to a friend who was doing cardiology, and I asked her, why she refer cases to me? And this is the conclusion that we came up with, which I will present today. Many people think that cardiology is like iced tea. It tastes excellent by itself. And palliative is like the lemon. Tastes good, but iced tea is excellent by itself. However, in my humble opinion, I feel that the best drink is iced lemon tea, where both are combined, giving this awesome taste that will quench our thirst. So coming to the first case, Encik Ali. He's a 65-year-old teacher. He's been admitted 3 times this year alone. He has heart failure because of IHD, and he also requires regular dialysis because he has end-stage renal disease. Over the past 1 month, he was getting weaker, although he still can walk to the toilet and he needs help to shower. His exertional dyspnea, which initially only occurs when he walks very far, is worsening and has now progressed to NYHA4. He was intermittently confused and intermittently restless and agitated, which is a distress to the family. He has a very supportive and very loving wife and also family members that constantly surround him, trying to do their best for him. His BP was 92/50. He had very minimal fine bibasal crabs and mild pedal edema. So the question is, what would you do? Please type your answer into the chat, and it'll be interesting to see everyone's answers. A, will you do daily hemodialysis to remove the excess fluid? Or would you do B, high-dose IV furosemide? Or C, counsel for heart and kidney transplant? Or D, this feels like a trick question. Quite hard, huh? So the conclusion that me and my friend came up to was number 1, palliative care helps with symptom control. Let's see how we help. Many studies have been done to see what were the symptoms that prevailed in patients who has heart failure. This was a little bit unexpected because 78% of them have pain. And this is not just talking about angina pain. We're talking about body aches, body pains in the trunk, in the back, in the extremities. And this is very often neglected as compared to cancer patients. And this has led to distress as it frustrates the patients and the family. The second most common symptom is actually dyspnea. And the interesting thing is that usually the dyspnea will occur when it is at the advanced stage. And when they move a bit, or even they talk a bit, or even if they were to eat a little bit more, they become very breathless. And they're just too tired to continue eating or talking. So they keep quiet, ending up sometimes isolating themselves. And because of this dyspnea and this isolation, many of them go into have insomnia, and they have depression and even anxiety, making an already very, very frustrating situation even worse. So Encik Ali has stage 3 advanced heart failure, meaning the symptoms has started to interfere with his daily life function, and he has had repeated hospitalization. These were his symptoms. 1, NYHA4, dyspnea, intermittent delirium, functional decline. For dyspnea, we taught him to do breathing exercises and also how to pace himself. So we taught him how to prioritize what are the important things that he would like to do, and to forego those things that are not so important. We also continue to diurese him as gently as possible with furosemide, or even medications such as bumetanide can be used. If it becomes intractable, then sometimes we may need to start a little bit of opioids to help him feel better. If he has anxiety, sometimes benzodiazepines at low doses, for example, low dose of lorazepam, will be able to help him overcome that distress. For delirium, there are 3 types: hyperactive, hypoactive, and mixed. So hyperactive means it can be restless, like, moving like that, or very agitated or very combative, like fighting and hitting. Hypoactive is that probably they are hallucinating, having delusions, but they are not reacting much. Or mixed, which is swinging between both. For delirium, it's very important that we need to treat the underlying cause. It could be as simple as an infection, or even some dehydration, or even electrolyte imbalance, or sometimes even as simple as constipation. If the delirium persists and doesn't get better, or while waiting for the underlying cause to be settled, then there are these methods that we can try to help them overcome. Usually we will advise to surround the patient with familiar people or objects. And we will encourage routines, such as when it is nighttime, to off the lights, and then after that, to limit the noise. If it doesn't work, then we may need to use medications. Do beware that haloperidol, we need to be cautious when we use it, because it may prolong QT intervals, which may lead to torsade de pointe. So other medications that can be used that are also very good and very effective are lorazepam or even olanzapine. This was a study that was done to see the role of palliative care and how effective palliative care is in patients with heart failure. So it used these 2 tools to measure the function and quality of life. The 2 tools were Kansas City Cardiomyopathy Questionnaire and the FACIT tool, the Functional Assessment of Chronic Illness Therapy Palliative Care Scale. So you can see the red line is usual care alone, and the blue line is where you see that the usual care with palliative care. So in these 2 graphs, it clearly shows that those who had received palliative care had better quality of life. On top of that, the HEAD scale was also better for those who received palliative care. So we are not only helping in the physical, we also help in the emotional. Suffering has many dimensions. It can be physical, emotional, spiritual, and psychosocial. One of my previous teachers used to say this: palliative care is very kepo, a very Malaysian-wise method of saying things. The kepo, it means in English, is busybody. We will correct a bit here, correct a bit there, to find out what is troubling the patient and to see how we can overcome all these issues and to see, to change what we can change and to help patient accept and change. So after controlling his symptoms, Mr. Ali improved. And the happiest thing he said was he could finally sleep better at night. He could make jokes and smile. His wife and family were so happy to see that. They were able to spend quality time with him, enjoying simple things in life, such as having family dinners and also watching TV together. So, palliative care helps the patient and family to live as well as possible for as long as possible. Second case, Mr. J. This is a very interesting gentleman. He's a 56-year-old retired soldier. He had advanced heart failure. Clinically, it was euvolemic. This time, he did not have any symptoms at all. Is there a role for palliative care? Let's see. His BP was persistently 80/40, requiring inotropes. He was offered home dobutamine therapy, but he refused, and hence he was referred to palliative. So, number 2, this is how palliative care help. We help with communication. I had a chat with Mr. J asking what does he understand about his disease and why he chose not to have dobutamine home therapy. He honestly didn't understand the whole concept of heart failure, and he didn't understand that dobutamine was there for to sustain his life. So I sat down with his family and him together and explained things to them and told him that whatever his decision is, we will respect, whether he wants the treatment or want conservative. He had a discussion with his children and wife, and they decided that they want the home dobutamine therapy. So, 2A, we help to bridge communication between the patient and the cardiologist. So his son asked me, he asked me in front of his father, how long more can my father live? I felt this was a very in question, and I felt there was more. So I asked him, why is this question important? So Mr. Ryan told me that he just accepted a new job offer that will require him to travel overseas immediately the next day. And the distance was more than 24 hours away. So he said, should he go? Will he be able to come back on time if his father deteriorates? This is a busy slide talking about trajectory from AHA. I found this a little bit too complex to explain, so I chose this. So this is the terminal cancer trajectory of disease. As you can see, initially patients are well, then subsequently they deteriorate. But for those with heart failure, each deterioration, it may be the last one, but many times it may not be. And they may go down, then get back up, go down, get back up, and we don't know how many times this will happen. So the patient may come in getting intubated each time and manage to survive each time. And each time during this intubation process, the family will be counseled saying that patient is critically ill and the patient could die. And then the next thing they know is patient got better. So then they don't realize that every time he deteriorates, he is still at risk of dying. And we don't know which time it will be the end. So hence, this is one of the problems that we face in explaining trajectory to family. Because it's so difficult to have accurate prognostication. There are some tools that we can use. One is the Seattle heart failure model. The other is the magic risk calculator. However, the sensitivity for predicting death in 1 year for these two tools are actually very low. For the home dobutamine therapy, there was a study called Rematch that said that the survival was 32% after 1 year. So how do I tell Mr. J and how do I tell his son Ryan 32% in 1 year? I don't know your father will be the 32% or not. So I explained to them regarding the unpredictability of the prognosis. And more importantly, I start to realize in the midst of seeing a lot of cardiovascular patients is that I found these tips very useful. If the symptoms were worsening, if they have dyspnea, delirium, cardiac cachexia, or their appetite is dropping, or they are declining functionally. If they have more than one hospitalization, and the more, the higher the risk. And if it involves another organ, such as cardiorenal syndrome, then these are some signs that things are not going to be so well. So I did family therapy, basically gathering them together, and then I helped Ryan ask his father whether he should go or not to go, because Ryan couldn't bear to bring this topic up. Mr. J told his son, go. Because he was previously a soldier and he was in the battlefield. When his own father passed away, he couldn't be there. He understands that sadness and that struggle. However, he also wishes for his son's best and his son's future. And he said, go, don't feel guilty about it, you have my blessing. And hence Ryan went with his father's blessings. So, palliative also helped to bridge communication between loved ones. Coming to the third case, Madam Maimuna. She's a very, very cute lady. She's 70 years old. She has been a homemaker all her whole life, taking care of her children. She had advanced heart failure, and every month she was admitted for fluid overload requiring BiPAP. This time, she was intubated, and they managed to wean off until nasal prong, and they couldn't wean down further. And she became bedbound. Amongst her children, there were two very dedicated daughters, Siti and Alia. They want to take care of her. They want to bring her home, but they are very worried. What happens if she becomes breathless at home? What happens if she becomes confused at home? What happens if she starts to turn blue at home? How do we take care of her at home? Number 3, palliative care helps with discharge planning and goals of care discussions. Goals of care should always be a shared decision making by those who are taking care of the patient and the patient themselves. The treating team need to recognize what are reversible and irreversible conditions. And we need to know what are the patient's preferences, values, and any upcoming important life events. So these are the few things that we will ask. What is the aim of care? Is life prolongation very important? If yes, then why? If the patient says that she wants to see her grandchildren being born, and all her children are still in their teens, haven't even finished studying, haven't started working, then perhaps this may not be a realistic goal. So for this patient, she had one goal. Her youngest daughter was getting married the next month. She hopes to attend. So this is perhaps something which is possible. The next thing we need to discuss is what is the preferred place of care, PPOC, and what is the preferred place of death, PPOD. Is it important for the patient to be at home? Some cultures and some religions, they would prefer home to be the place to be. Some people will say that, no, I don't want to burden my family. I want to be where I can be the most comfortable. Or even a very realistic reason. I don't want the price of my house to drop if I were to die there. So these are very realistic things that the patient will be concerned of. So we will need to try to address these issues. The next point will be the extent of care. To what extent are we going to treat? If the patient were to get admitted again, are we going to intubate her? Are we going to start inotrope? Are we going to admit her into ICU or CCU or general ward? And if the patient has devices such as ICD, and if let's say the arrhythmia is so bad and the patient gets shocked every single day, it's very painful and very distressing. However, stopping and deactivating the device means that the next arrhythmia could be the fatal one. These are very important things to consider, and these are very important conversations to have to understand what does the patient understand, and is the outcome something that the patient can accept, and is the outcome something that the family can accept. Home preparation. We need to talk about symptom care plan. So as I mentioned just now, Siti and Alia were very worried because what happens if the patient has sleep snare at home? So we came up with a symptom care plan telling them what to do, teaching them how to react if she's breathless, and what are the medications to give, when to give, what are the intervals, and what is the maximum per day. So we empower the family to manage symptoms at home. We also help with caregiver planning. If there's only one person to care for someone, where the care burden is so high, one person 24/7 is not realistic. They will become burnt out. They will become exhausted. So hence, we will advise, usually try to get other family to chip in or to hire another person if financially they are able to. If not, then perhaps have to consider institutions such as nursing home. If possible, we would like to link them to the community palliative services. This will include hospices or domiciliary care, or some hospitals such as IKN, where they have home care to see palliative patients at their home, at the patient's convenience. Because sometimes it's very difficult to come back to the hospital, especially if they are on wheelchair or worse, they are bedbound, which means that they will have to get ambulance just to come. So linking them up with community palliative services will help the patient and family to cope better and to reduce their stress. Equipment. Can the family afford to buy a hospital bed or even oxygen concentrator? Or are there any organizations around them that can rent, or even better still, lend it to them for very minimal price or even for free? So these are things that we will guide the family to plan. And if hospital bed is not feasible, then we will guide them and see what are the other alternatives. So we empowered Siti and Alia to take care of the patient. We referred to the hospice and gave them a brief explanation of what hospice service is. And we also helped them to get this equipment, hospital bed and oxygen concentrator. This is because they live in Klang Valley and there are more resources in Klang Valley. And if the patient were to deteriorate or pass on at home, we guided them and explained to them what should be done. Madam Maimuna managed to see the wedding of her youngest daughter the next month and passed away a few months later. So palliative care is more than what most people think it is. It helps us to have conversations with the patient so that they know what to expect, so that they have a bucket list which they will want to try to finish all of it. Sometimes they may not be able to do all, but at least we help them set realistic goals and achieve what they can do. If they can't do skydiving, perhaps they can take a holiday. If they can't climb Mount Kinabalu, maybe we can help them to go to Genting for a ride. It also helps them make plans and new memories. For those that are not married, maybe they want to marry. For older couples, they might want to renew their marriage vows. In palliative, it's very exciting. We have seen graduations, and we have seen marriages. We have even organized a marriage ceremony for the patient, and also many birthday parties. Do palliative is quite fun. I always found this cartoon very cute. Charlie mentioned to Snoopy, someday we will all die. Snoopy is very wise. He said, true, but on all other days, we will not. So rather than focusing on when they are going to die, we help them realize that yes, that day will come, but it's more importantly to focus on the now, on whatever that they can do, so that they can do whatever they want as long as they want. I will not talk about end-of-life care, but this is a symposium that my hospital is organizing. This is a collaboration between HKL and also HSAJB, where we talk about how to live well till the end, how we can help patients enjoy life till the end, and how to help family cope and to go through those tough times. This is the website for Palliative Care HKL. This is the link, the tinyurl.com/PCUHKL, and that is the QR code. Over here, we post resources and also the flyers of events and courses that we will hold for the year. So if you're interested, do check out our website and join the courses if you find it interesting. So the AHA came up with this guideline of recommendations. So they say that those patients who have heart failure, what they say is that they should be referred to palliative care so that we can help to improve their quality of life and also to relieve suffering and also to do shared decision-making on goals of care. So the 3 things that we learned today is also part of this guideline, where we talk about high quality communication, conveyance of prognosis, clarifying of goals of care, shared decision-making, symptom management, and caregiver support. Because this is quite difficult times to go through, and the caregivers usually are very exhausted, and they're also very frustrated, and they're also very scared. So we also try to relieve or reduce their suffering as much as possible. And we try to be a shoulder for them to cry on if they need to. Benefits of palliative care in a nice and simple table: the physical, the psychosocial, and the spiritual. We relieve their pain, manage their symptoms, and mitigate discomfort. We try to provide emotional and mental support to fulfill goals and desires. Spiritual, we try to empower and help them find purpose and closure. So now that we've seen why we should refer to palliative care, then I will want to expound on the next question. When should we refer to palliative care? Unfortunately, it's a lack of consensus, and many times referral comes in too late. When the patient is about to die within the next few hours, or going to die within the next 1 to 2 days, it's a little too late, because we want to help them live even better months, if not years ahead. Ideally, palliative care should be earlier, and we should always integrate palliative care as a routine to patients with heart failure, and don't rely solely on prognostication. It should be a needs-based criteria rather than a disease-based criteria. So I found this interesting, where those with stage D, advanced heart failure, they recommend to refer to the heart failure specialist and also refer to palliative care. So this is the acronym, I need help. I is IV inotropes, NYHA 3 or 4, and organ dysfunction, ejection fraction less than 35%, defibrillator shocks, more than 1 hospitalization, edema, low blood pressure, and prognostic medication. When this medication, they become intolerant and down titration is required. So complex. I don't know when to refer still. There's so many things to remember. So being palliative, we like to simplify things. So when they are symptomatic, admitted more than 1 time, they are getting weaker, or based on this, the surprise question. Would you be surprised if the patient were to pass away within the next 1 year? If you feel that you will not be surprised, then it is a good time to refer to palliative care. In the ideal situation, we want to get to know them when they are still well. If possible, we want to see them when they are still able to come to our clinic so that we know them better and we can start to have conduct serious and difficult conversations. Supportive care or palliative care, whatever the name is, it needs early integration. We promote patient-centered care, symptom management, and preparedness planning, where we assist in complex decision-making. Ultimately, it is to enhance their quality of life, to live as actively as long as possible. If you know this movie, it means you are as old as I am, or you're even older than I am. This was a movie that came out when I was in school, when Harry met Sally. They were together on and off for 12 years, and after a very, very long courtship, only they married. So palliative and cardiology is the same. When palliative and cardiology are separated, yes, we all still can do a lot. However, when we combine, we achieve better outcomes. Patients live better, family live better, and we have better satisfaction knowing we help the patient to improve their quality of life. I would like to end with a video.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care, specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists, all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy, and be sure to consider the enormous potential of palliative care.
In summary, palliative care in cardiology helps with these three aspects. 1, reduce suffering physically, psychosocially, and spiritually. 2, we help with communication. 3, we help with discharge planning and goals of care planning. 2, patients with heart disease should be referred early to palliative care so they can live life to the fullest. Thank you.
Thank you, Dr. Lim, for your excellent lecture. So, Dr. Lim has given us a concise yet informative lecture covering the role of palliative care and the timing for palliative care referral for patients with cardiology disease, diseases. So now it's time for questions and answers. So I really encourage all the audience to type your questions in our Q&A box, and I'm going to read out for Dr. Lim to answer. So our first questions from WH. His question is home dobutamine available only in cardiac center?
Okay, I think the best person to answer this question is the cardiologist. I'm not aware of the entire Malaysia setting, but I do know that IJN offers home dobutamine therapy. So when I was doing my fellowship in Singapore, I had the opportunity to see patients from the heart center in Singapore. And this was something that's very common over there. In Malaysia, the other cardiac centers, I'm not aware. Perhaps we can ask this question to a cardiologist in the future.
Okay. So, okay, thank you, Dr. Lim. I think at the present time, it's still not easily available in every center. Only certain cardiology center offer home dobutamine. So I think it needs coordinations and then lots of support and resources as well. So check out with your local cardiologist and find out whether it is possible to use it. And then I think like what Dr. Lim said, shared decision-making, discussions, communications should take place before, before the intervention takes place. Okay, we come to the second questions we don't know with this. So he said, coming from a limited resource region and specific care is scarce, okay, as a primary caregiver, or this is a primary care physician. So what are the resources I should use for patients that are potential palliative candidates and help them connect with their condition more?
I think this is a very interesting question, Dr. Yet. So it really depends on what do you understand by what palliative care is. Is that what are the resources? Because if you are talking about resources, it depends on the condition. And it depends what are the things that are needed. So if let's say, if the patient is bedbound, then let's specify to cardiovascular patients. Yeah? So the common things that they will need is that if they are wheelchair bound, then perhaps they will need a wheelchair. They may need a commode. And if let's say they are bedbound, then perhaps they will need a hospital bed. But these are not absolutes because these are things that require money. And a lot of times, a lot of our patients don't have that. So if a hospital bed is not available, then a simple bed rest could be an alternative, a back rest could be an alternative. This is easily available for about 100 ringgit in the nearest pharmacy. If this is not possible also, then we also can adapt using more pillows or using bolsters to lift the patient up. Yeah, and if let's say, if there's a commode, great. If there's no commode, not an issue. We can use the wheelchair to bring the patient to the toilet. So these are just things that requires a lot of adjustments and a lot of creativity. So hence the occupational therapist is very important. I know this occupational therapist that does home services. His name is Raymond. He's very, very wise and very, very, sorry, I think they're doing renovation upstairs, so you will hear some funny sounds here. He goes to the patient's home and see what is available, and he adapts from there. So like things, right, he will go and look for things in the kitchen. He'll ask for permission, goes to the kitchen, go one round, and then start to take things from the kitchen, utensils, or even small plastic cups, and then let the patient use to exercise. So these are adaptation, realistic adaptations. So hence having OT and PT in is very important. And if let's say, even for example, how to turn a patient, how to change a diaper, these are things that the nurses can teach them. If not, then any nurse in the KK, which is usually in every area that should be one, they also can guide the family on how to care for a patient. So it is not to say that only someone in the city should get palliative care. So there's this lady in Uganda. Okay, she's not from Uganda. She's actually from one of the Western countries. Her name is Anne Merriman. Don't know why she had this burning desire to help patients in Uganda, and she happily migrated there. And she went around getting funding for Uganda. So the problem was in Uganda, the people were so poor and they don't have access to sufficient technology or even treatment. So there are a lot of patients that became conservative and then progressed and then became advanced disease. So when this happened, what do we do? So hence, palliative care became a very important component in that country until the day where they have enough resources to build their cancer treatment and their cancer centers. So hence, she goes around helping the patients relieve their symptoms. Because those who have cancer, they have a lot of pain. Then she will go and try to get funding to at least buy morphine in Uganda. So these are very important things that we can learn from. Just because if you are in a place far, far away, because I see the next question saying that if to see a palliative care specialist or palliative care consultant 200 km away, that's ridiculous. To ask anyone to travel so far is ridiculous. There's no other word for it. For me to travel 30 km to come to work every day, I'm already very tired. You ask them to travel 300 km or 200 km to see someone, it's not realistic. So what we hope to do is that this is the national plan for Malaysia, is that everyone can do basic palliative care. It's like everyone can treat pain with simple medication. If you have Panadol, great. You have Tramadol, great. You have Voltaren, Ponstan, great. If you have morphine, even better. Feel free, sorry, I do a bit of promotion, yeah? Feel free to join the Zoom webinars that HKL organizes, because for the past few years, we have been doing introduction to palliative care, teaching basic principles on how to manage simple symptoms. So at least you can relieve the suffering of your patients at the local level. And if the care gets more complex, then there is always a call to your local referral center. So for example, Dr. Yet alone, although she's based in Ipoh, she's an amazing woman. She covers so many places. She goes to Taiping, she goes to Batu Gajah. Dr. Yet, where else do you go to?
Manjong.
Yeah. So it's just amazing. And from there, she trains people and who continues to train. And we constantly conduct courses, not because we want to promote ourselves, but because we want to teach palliative care so that we don't miss out on anyone. And if the case becomes difficult, feel free to contact your state palliative in charge. Because now in Malaysia, nearly every state has one palliative consultant that you can definitely approach. We will not reject. Yeah. So yes. So that is my little opinion.
Yeah. I totally agree with Dr. Lim actually. So palliative care is everyone's business actually. Even from primary care, you will see more patients than us actually. So but to be enable yourself provide good quality of palliative care service, you need some training, you need knowledge and skill. So like Dr. Lim said that they are organizing webinars. So do find them and then register with their website. And also they are ongoing like this College of Physicians, I think, but it's usually yearly. So for palliative care, and then your local. So I think every year, like what Dr. Ling said, almost every state have palliative care physicians. So we are doing ongoing training, educations, courses actually for MOs, for nurses, for specialists from district hospital. So for my setting, actually, there's only one palliative care physician in Perak, the whole state. So we train people there so that they can handle most of the problems. So when they come to difficult, complicated problems, always feel free to call us and discuss. So we will guide you. And then if it happens that we do visit those hospitals, sometimes may not be very frequent, we will definitely go and see the patients. But it can nowadays actually, sometimes may not be needed in-person meeting, so we can actually do virtual discussions, and then even we can see our patient virtual, in a virtual clinic. Then we will try to discuss on how to help the patients. So when you and me come together to help patients, that will be very powerful. Okay. So we have other questions. I focus at Q&A first, then we will go back to chat. Okay, Can you share the link? Oh, okay, I think the same question in the chat. So to HKL palliative webinars, I think Dr. Lim just now you shared, right? But maybe at the end of the webinar, I think Dr. Lim can post out the link again. You had to scan, if I'm not wrong, just now she put out. So, and okay.
I can share it now again.
Oh, it's
Sorry,
there already. Oh, Dr. Lim posted up. Okay.
Yeah.
Okay. Yes. Is there any other questions? I think we have answered all the question posted, right? We still have time, I think. Still have 8 minutes. I would like to ask Dr. Ling one question. I think Dr. Ling has said that actually as palliative care team, we do a lot of communications, right? So one of our role is to communicate with patients. I would like to hear from Dr. Ling's points of view about advanced care planning for patients with advanced cardiac diseases. Dr. Ling have seen so many patients with advanced cardiac disease. I think probably she can share with us some of her experience doing advanced care planning with patients with advanced cardiac disease.
Not that many, Dr. Yet, only a few. Yeah. So I think doing in HKL, what we do is that we use the term goals of care rather than advanced care planning because we want to have an idea of what is important to the patient. So hence, we use this term goals. And when we have this discussion, we want to know what are the important things in their life. So, and what do they understand by how things are at where they are now and what do they expect? So sometimes it can be very extreme. So they, on one end, they think that they will live forever and ever. They think they are going to be around for the next 10 years, although they are already very unwell, bedbound. So that will be something that is challenging. But on the other hand, they will be so breathless that they think that they are going to die immediately. So hence, this is something that we need to find out what is their perception and to clarify with them. Just because they feel dips doesn't mean that time is in spite of adequate diuresis. That means the pump is failing. So that is a sign that we have to watch out for. So we will have to clarify. And then the next thing is knowing all these things is that where do they want to be? So I saw this movie where this young girl, I love to watch movies, Dr. Yet. Yeah, so I watched this movie where there was this young girl who had cancer, who was stuck in the hospital for so long, and she was dying. The parents couldn't let go. The mom couldn't let go, wanted her to stay in the hospital to get treatment as much as possible. It took them a very long journey to finally accept that the daughter is dying. And when that time came, they were very clear. The daughter wanted to be at the seaside. So the family brought her to the seaside. So these are some things that we try to help the patient achieve. If let's say it is important for them to be at a place. So because KL is a very central area, we see patients from all over Malaysia. We see patients coming from even Sabah, Sarawak, Terengganu, Teluk Intan, Kedah, Alor. We see them from all over. And sometimes going home is a desire that they will want to have. So if let's say they want to go home to Alor, the first question is the patient stable enough to go back? The second question is, can the family afford to bring back? Of course, this one, nowadays, we have so many charitable ambulances. This is something easily achievable. But then the next question is, will they survive the journey back? And will the patient and family be able to accept if the patient were to pass away halfway through the journey? So these are conversations that we will have, and to find out what is acceptable to them and what is not acceptable to them. If let's say patient's desire is to be at home. So there was recently a case where the patient wanted to go home, but the family were already very burnt out and they cannot cope at home. So we also had to bridge that with the patient because the family couldn't bring themselves to tell the patient no. So we sat down with the patient, talked to him, and explain that, yes, we would like you to be home if possible, but this is not achievable. Will an alternative be like going home for half a day or even a meal be an alternative that is acceptable? If yes, then we will try to arrange. If no, then we will also try to explain to the patient.
Thank you, Dr. Lim. So, Dr. Lim, we still have a few questions need to answer. I think first is they were. I think they asked about the link for HKL palliative webinars is posted up in the chat box. I think the audience can refer to the chat box. Okay. So, and then I think another question from the same doctor, I think from district hospital or from primary care. So he said that he or she said that the problem with them is the limitations of the availability of medicine for palliative care. I think what you are referring to, is it opioids? I think maybe because other medications like laxative or other nausea vomiting medicine, delirium, like haloperidol should be available. So so they hope that they can get more resources and dedicated palliative team to run their own community palliative services. So I think we have very successful domiciliary palliative care team where, I mean, in Selangor and in Perak, we have excellent domiciliary care palliative care team. They have actually morphing with them actually, and they do adjust the dose for patients during their home visit. Maybe you all can, I mean, talk to each other and find out how they work it out. Okay. So and another question is, can hospice monitor patients at home or on home dobutamine? If not, how is it monitored at home? Dr. Ling, would you like to answer this question? Do you have any experience dealing with this group of patients?
So for the home dobutamine patients, they have a very excellent service to monitor the dobutamine and the care, and they teach them quite extensively. So how to care for the syringe driver, how to change, what to do in emergency, how to deal with basically sort of like a Q&A and a FAQ kind of thing. If things go wrong, what they should do. So, and also they see the patients quite regularly and also the family quite regularly. If I'm not mistaken, they see them up to weekly. So in that sense, the home dobutamine per se, the team that prescribes it will monitor it. But of course, hospice team can also go in to see the patient as a whole and also to help to see when the syringe driver is not functioning. Will they monitor it per se? The answer is, if they're seeing the patient, that will be something that they will have to take into consideration. But monitoring the home dobutamine service, usually the cardiologists have a very good and established team to monitor it themselves.
I think I have not come across any patients on home dobutamine, but I heard of it, I mean, from my team, my colleagues. So I think we always work together with the team that supplying home dobutamine. So if you, during the hospice team visit, if we encounter any problem, we probably, I think it's always okay for us to give a call to the treating team and then discuss and then get their opinion and then give them some feedback, what is going on actually. It's always, I mean, we work together, like what Dr. Ling said. When two come together, it will be very powerful. Okay, so I think we go to another questions. Okay, time is running out. So, okay, Dr. Lim, this question is, what do you wish doctors in clinic kesihatan or districts or rural area, okay, be mindful when encountering these palliative patients?
I will summarize it. If there's only one thing that any doctor, be it whatever level, be it hospital level, KK level, GP level, rural level, wherever you are, because I've served in Sarawak before and I've done covering to very district places. Then I have a hobby. Whenever I go for holiday, I will go and see the hospital. Even when I was traveling within the interiors of Sarawak, I happily go and visit the KKs just to see, oh wow, so amazing, so interesting. So I think that honestly is not really how much you can do All you need is a willing heart. A willing heart, everything else can settle. You need training, no problem. You want to learn, no problem. Phone call, someone will be there to help. And resources, you have equipment, great. No equipment, great. No issue, we will also can modify. With or without equipment, we can take care of a patient. So all you need is honestly a willing heart and a phone to call.
Thank you, Dr. Lim. So I think one last question posted by, I think, Dr. I think from Primary Health. So she said, is there any opportunity to enroll to any palliative care fellowship program locally or abroad?
Yes, definitely. So I can't believe I'm happily promoting this. Yes. So we have a lot of courses. We have one-day courses. We have 30-hour courses for the allied health, for the nurses, the MAs, for the OTs and PTs, even pharmacists. There is a lot of courses. There's something called ADPC, which is the Advanced Diploma of Palliative Care, which is a one-year course. This has been running, and recently I went to visit IKN to see their community palliative service, which is run literally by the nurses. And I tell you, they are so amazing. I was so impressed, and I hope to be able to replicate that in my own center. Dream. Yes, that's the ideal. Yeah. So hence, if you're interested to learn, if you're from this group, try to consider ADPC if you can commit. If not, there are a lot of short courses. So for example, there are some short certificates, like let's say in Singapore, there's something called the palliative care. Just Google palliative care certificates. Even there's one from India. So I don't know whether it's good because we had COVID or not good because we have COVID. Of course, it was a very horrifying time, but at the same time, it opened up a lot of virtual teaching. So we saw that a lot of people started to use Zoom, like even the one that we are attending right now, is that people start to hold courses, certificates, diplomas for palliative. So do consider doing that. If let's say you want to further study and do palliative care, let's say you're so in love with palliative care and you want to focus only on palliative care, even better. So palliative care in Malaysia is a subspecialty. Tentatively, there are two pathways to do it, which is the medical pathway, where you do medical followed by palliative, or you do FMS followed by palliative. So this is an excellent pathway. Dr. Yet, I'm not sure whether oncology background or surgical background can do. So it really depends on to what extent you want to do. And there's something called like Flinders or the UK one, sorry, Thought Block. The name of the UK one is Cardiff. Yeah. So these are also very excellent courses to do. They have diploma, certificate, master's, PhD. If you want to do PhD, please go ahead. My dream is to do PhD, just that everything is in, convert, UK, US, yeah, so it's very expensive. If you have the opportunity, please go and further your study. We believe that after you study, with knowledge comes empowerment, and with empowerment, we can continue to help patients better. Yeah, so we can reach out in a bigger and wider scale. Yeah, so yes, do consider doing palliative. Feel free to reach out to your local lovely palliative people. They will guide you in where to go and what to do.
Yeah. So it depends actually what do you want. You want a short course just to improve your knowledge and skills. Then I think Dr. Lim has mentioned all those short courses, even whether it's local or overseas. So, but if you want a proper program, which will be your subspecialty if you are a doctor, so palliative medicine comes as a subspecialty. There is no master program in palliative care. You can go through family medicine pathway or go through a physician pathway. Of course, we would not reject surgeon, or even if you're from oncology background, you can always approach us. Then probably your program will be slightly different from others. So we welcome you to join us. So for doctors, so for nurses, go for advanced diploma in palliative care. So we have been doing this wonderful course and train many nurses. occupational therapists, physiotherapists, actually for the past 8 years. So do join us. Okay. So I think Kelvin, I think that no more questions. Just let me check again. Okay, the organizations, I think we mentioned about that. So if you still not sure, you can always discuss with the palliative care physician in your state, or if your state doesn't have a palliative care physician, you can call any one of us. We will definitely very happy to guide you through. Okay, Kelvin, shall I pass back the time to you, Dr. Kelvin?
Yes, okay. Thank you again, Dr. Lim, for the wonderful talk, and Dr. Yet for chairing the session. Thanks, guys, for joining the webinar.